In this video, we're going to be discussing the 12 pairs of cranial nerves as they pertain to the notes found in PNS, structures, and then reflexes. So, of course, with the cranial nerves, there are 12 pairs, most arising from the brainstem, and many of them are mixed. And we'll find that a great number of them actually carry fibers associated with the parasympathetic division of the autonomic nervous system. We'll discuss that more in the next chapter. And what's interesting here about these nerves is that most of them work in an ipsilateral categorization, while just a couple here are going to be functioning in a contralateral facet. So, of course, review this image. The best way to memorize the Roman numerals for each of these is to memorize them in order. So just begin up here with the olfactory nerve being cranial nerve number 1, and move your way down, and they go in a relative order all the way through there. Of course, here you want to review basic functions, sensory and motor, but we're going to elaborate on those. Again, this image here, this nice illustration, can help represent sensory and motor for those of you who are visual learners. So we begin with cranial nerve number 1, the olfactory nerve. This is a primarily sensory nerve with the function of mediating smell. It originates here in the olfactory mucosa of the nasal cavity, and it's going to pass through the cribriform foramina here of the ethmoid bone. It terminates right there on the olfactory bulbs, and these bulbs themselves essentially represent where those incoming olfactory nerves can then begin to transmit messages down along the olfactory tract, and it is eventually going to make it to the thalamus before it's relayed to the olfactory cortex so that you can interpret what it is that you're smelling. So if you damage these cranial nerves right through here, you of course have an impaired sense of smell, also known as an anosmia. Cranial nerve number 2 is the optic nerve. Again, this is going to be a sensory nerve, primarily responsible for vision. And it originates here on the retina within the eye, within that posterior chamber. And the retina is going to have specialized receptors known as photoreceptors that respond only to light. Now, as you can see here, the optic nerve is going to run all the way back here to the optic chiasm, and then it's going to split back into optic tracts, terminating then on the thalamus and the midbrain. As I mentioned here in the notes, those optic tracts, once they run to the thalamus, will actually have projections that run back to the primary visual cortex. So that's where you're actually going to be interpreting what you're seeing. Of course, as you begin to damage this, it's going to result in blindness to some degree. I make a note right over here that these are referred to as inopsias, and that damage can have differing effects depending on how it relates to the optic chiasma. We'll discuss more about why this is later on, but for now you need to know that damage prior to the optic chiasm is going to cause blindness only in one eye, and then damage beyond can result in partial blindness in both eyes. Cranial nerve number 3 is oculomotor. As you can see from its name, it is a predominantly motor nerve. It's going to originate here in the midbrain, as you can see, and it's going to actually run to innervate 3 of your extrinsic eye muscles. So this is going to be the superior, the medial, and the inferior rectus muscles of the eye, which have varying functions. And this is not the only kind of motor output that you see. As you can look over here, you find that you're also going to have the ability to promote essentially constriction of the eye, where the pupil itself is going to diminish in diameter, as well as cause contraction of the ciliary muscles of the lens. Now, what we're going to see here is that this is responsible for helping you to see close up as though you were reading or looking at a computer. And so when you have damage to the oculomotor nerve, there's pretty varying effects of diminished activity that you have. You can see these over here: drooping eyelid, dilated pupil, inability to move the eye, and of course double vision, since we're seeing here the inability to align one eye with the other eye. Things tend to look pretty blurred. So of course, if we're looking only at the effects of the extrinsic eye muscles, the overall effect is that you tend to see external strabismus, and this is where the eye just rotates laterally because that lateral rectus is still intact and functioning, and it just begins to pull the eye in that direction. The term ptosis right here, not ptosis, but ptosis, is actually the term we use to describe that droopy eyelid. We move on to cranial nerve number 4, the trochlear nerve. The trochlear nerve is the only one that's going to undergo complete decussation, which means this is the one of the 2 nerves that we discuss as being contralateral in its activity. Once again, predominantly motor. It's going to mediate eye movements as controlled by the superior oblique muscle right through here. It leaves here from the posterior side of the midbrain. It's the only one to do so, and passes through the superior orbital fissure to run up through that orbital cavity and innervate that eye. Again, since this is going to typically influence one eye and not the other, if one cranial nerve is damaged, that means the two eyes are not going to be able to focus on the same thing. So once again, you see double vision and weakened ability to move the eye where it needs to go. So the eye tends to drift superolaterally because you essentially would assume that the oculomotor and the abducens nerve are still controlling effectively. Cranial nerve number 5 is the trigeminal nerve. This is the largest, and of course the reason it gets the name trigeminal is because as it leaves from the pons right through here, it actually branches into 3 separate segments. You have the ophthalmic division right here, which passes through the superior orbital fissure, running up to the face and the nasal mucosa. Right through here, you're going to have the maxillary division, which is going to move right here through the foramen rotundum. And then finally, you have, passing through the foramen ovale right here, the mandibular division. Right? So as we take a look at this, we find that it is a mixed nerve. The ophthalmic and the maxillary divisions are primarily sensory. And so as we look at their origin and termination, we find that the ophthalmic division is going to originate here at the skin and the muscles of the face, as well as the lacrimal glands themselves, and the superior nasal mucosa and sinuses. And it's going to run back to the pons. And it tends to give you sensation there associated with pain, as well as essentially just touch and temperature. If there's debris present in the nasal cavity, you can feel that. When you have sinus infections, this is the part of the nerve that relays that backwards. The maxillary division, also conveying sensory information, runs from nasal mucosa as well as maxillary sinuses. And this is where you start to see sensation from the upper part of the teeth and the gums. So if you've ever had brain freeze before, when you're eating ice cream too quickly and it makes the roof of your mouth too cold and you get a headache, that's actually a sensation primarily being carried by the maxillary division of the trigeminal nerve. With the mandibular division, this is where you see more motor function tied in with sensory. So still with the sensory function here, you have receptors there on the lower part of the face. It's going to include the tongue as well, but not conveying the sense of taste. Here, this is just going to give you the sense of texture and touch on the surface of the tongue, relaying all this sensory information backwards to the pons. For the motor division here of the mandibular branch, you find that it tends to actually run from the pons all the way up to muscles like the digastric, the masseter, the temporalis, the mylohyoid, and the pterygoid muscles. And this indicates here that this muscle or this nerve is going to be pretty important in allowing you to chew. So it's trying to stimulate the movement of the jaw, both for elevation and depression, and then also that side-to-side lateral excursion. We also find that it innervates the tensor tympani muscle of the middle ear. This tightens up the eardrum to help essentially make it more fine-tuned and acute to any kind of vibration through sound waves which is taking place. It's the trigeminal nerve. Cranial nerve number 6 is the abducens nerve. It's the last that we look at here as we begin to discuss eye movements. This runs, of course, to the lateral rectus of the eye itself. This tends to run out here from the inferior region of the pons right before the medulla begins. And as we've seen with other examples, whenever this nerve is damaged and the lateral rectus muscle can no longer contract effectively, we tend to see that the eye will just rotate medially. So we tend to call that an internal strabismus. Cranial nerve number 7 is the facial nerve. This is a mixed nerve. Let's begin first by taking a look here at how it branches. So whereas the trigeminal had 3 branches, the facial nerve has 5. And so a really good way to convey this is to lay your fingers across your face and get the idea of where all 5 branches will run. You have the temporal division, the zygomatic, the buccal, the mandibular, and then of course right down through here you're going to have your cervical region. Right? So in looking at the functions, we'll begin with sensory. So the sensory function with facial nerve is associated with taste, as it originates here on the taste buds of the anterior 2/3 of the tongue. It's going to run back to the thalamus and then be conveyed to the gustatory cortex, as we've discussed in earlier sections. As we move here down to the motor region, we find that it actually is going to originate in the pons, and it's going to run out towards the somatic muscle fibers associated with digastric muscle. So it does play a role in chewing, much like what we've seen already with the trigeminal. It's also going to run to the stapedius muscle of the middle ear, again fine-tuning the location of ossicles so that they vibrate accordingly, and you can hear things more acutely. They also run to things like the stylohyoid muscle and then muscles that are associated with facial expressions, things like the buccinator muscle, the depressor anguli oris, things like that. And so this is what's going to help you smile and convey communication through moving your mouth and your cheeks to some extent. So of course, when you have damage to the facial nerve, you lose a combination of facets. You lose your sensory ability for taste, but then you see the greatest amount of damage in the inability to move parts of the face that you normally would be able to. And keep in mind here that this is still an ipsilateral nerve, and so if you only damage one of them, then you tend to see the effects of sagging on one side of the face, but not the other. Now, when this is caused by well, this can be caused by something like herpes simplex virus, but is also associated with chronic stress, as it's been seen before, sometimes with massive hormonal changes. It's usually referred to as Bell's palsy. Now, of course, you can see here images of what Bell's palsy would look like. So here you can see the side of the affected nerve. So that would be the right nerve that was actually damaged in this situation, allowing the muscles to sag. And George Clooney is kind of the poster child for Bell's palsy itself. You can actually see in the image of him back in high school where Bell's palsy has its greatest effect. Now, and of course, with the way muscles work, when you have Bell's palsy that lasts for a long time, you have a certain amount of atrophy that takes place in the muscles. And so even if it lets up, essentially, and you regain control over the nerve, a lot of those muscles are eternally weakened, if you will. And so even when the individual's with this smile, you can still see the sag right there on his side of the face. Doesn't make him any less attractive, however. So we move cranial nerve number 8 now, the vestibulocochlear nerve. So this again is predominantly sensory as it's associated with hearing and equilibrium. So it originates here in the cochlea, which is the hearing component of its sensory capabilities. And then where it originates here at the vestibule and the semicircular ducts of the inner ear, that's what's associated with equilibrium. The minor motor compartment that we see here actually runs to hair cells within the cochlea, and these hair cells, once again, are going to be modifying the sensitivity of the sensory components there, allowing you to hear more acutely. So when you have damage to the vestibulocochlear nerve, you have a number of factors that arise from it. Of course, the one that we think of the quickest would be something like nerve deafness, and this is where the rest of the components of the ear will function appropriately, but you cannot send the signals all the way to the brain so that you can hear and then interpret that kind of a sound that's taking place. All right, we move on here to cranial nerve number 9, the glossopharyngeal nerve. So this the term glosso, of course, indicates the tongue, pharyngeal indicating the pharynx, the muscles that are associated there. It's mixed, so you have functions associated with sensation. The origin for these sensory fibers is going to originate as far as we can see here in the pharynx itself, and this is where you're going to tie in the gag reflex, the ability to swallow, because you can feel the food that moves down the throat and then reflexively respond to that. We also find that the motor compartment right over here is going to affect salivation, and that's because it tends to run to one of the salivary glands. And so when you have damage to the glossopharyngeal, people can sometimes have a dry mouth, essentially. They can't actually produce the saliva that they would normally be able to. Cranial nerve number 10 is the vagus nerve. The vagus nerve itself is a pretty long and winding nerve, and so its name actually means the wanderer. And so you can see it here, making its route all the way through the jugular foramen, through various parts of the body, here to the pharynx, down here to the carotid sinus, which is associated with blood pressure, and then, of course, innervating a lot of your involuntary organs, the lungs, the heart, the liver, the stomach, the spleen, the kidney, and the intestines themselves. And so we look here again at the fact that it is mixed. As far as sensation goes, we find that it's going to help play a minor role here in taste, along with that glossopharyngeal nerve. And of course, any sensation you have within the digestive tract, vagus nerve is going to relate to you if you feel full or if you feel hungry, if you have discomfort within the intestines. and even the urge to defecate. All of that's going to be relayed by the vagus nerve itself. For motor compartments here, it does assist with swallowing due to that pharyngeal innervation that you see, and of course tongue as well, so it's going to influence speech and your ability to eat. When you think about those involuntary components of the nerve, it actually is going to influence heart rate as dictated by things like the medulla and the pons, as well as bronchoconstriction, which is going to reduce the amount of airflow that takes place through the lungs, and then of course GI secretion and motility. We move on here to cranial nerve number 11. This is the accessory nerve, sometimes referred to as the spinal accessory nerve because it actually branches off of the spinal cord. It doesn't come off of the brain, and so it's a little bit of a misnomer to refer to it as a cranial nerve. But it gets grouped with all of these because of the fact that it actually runs up from the base of the spinal cord and actually is going to exit through the jugular foramen. The greatest effect here of the accessory nerve is its influence on the trapezius and the muscles of head movement. And so when you have the ability to lift your shoulders up and elevate, that actually stems from the activity here of the accessory nerve. Finally, cranial nerve number 12 is the hypoglossal nerve. Again, predominantly motor, so this is not there for taste like the others that we've seen. And this is going to be really important for the movement of the tongue, both for the extrinsic and the intrinsic muscles. So when you look at your ability to actually stick your tongue out or to move it during speech or during chewing and swallowing, that's highly tied to what's happening with the hypoglossal nerve. Now, even though you've got the tongue seems relatively small, you are going to have symmetry in the musculature that runs through the tongue, and that's one reason you have to have two nerves, a right and a left hypoglossal nerve that run to it. So again, if you have damage to just one hypoglossal nerve, what we find is really similar to what we saw with the eyes. On the side of damage, since this is ipsilateral, we find that the muscles themselves don't function and they undergo atrophy. Whereas on the side that's unaffected, those muscles stay very strong and can essentially overpower the muscles on the side of the damaged nerve. And so the tongue, if you try to stick it out straight, won't actually do that. So it's a really great way to visualize the ipsilateral function of the hypoglossal nerve. And that ends our discussion here on the cranial nerves. So make sure as you go through that you are memorizing from these tables composition, function, origin, termination, cranial passage, and effective damage, as well as any additional notes that I provide you in writing. You will not be asked to draw or to identify any of these nerves. However, knowing which cranial passage they come through and then which region of the brain stem they actually are associated with, the best way to learn that is to actually look at images while you're studying.